So good morning and a very special welcome not only to our usual members of the Department of Medicine who attend these grand rounds, but also our other Christiana Care colleagues from various departments, and especially to our community members who are here today to join in not only at grand rounds, but a program to happen right after. This is the 10th year that the Department of Medicine and the Community Center of Excellence in Women's Health have co-hosted an annual visiting professorship. And it's a great treat today to have Dr. Anita Nelson, Professor of Obstetrics and Gynecology at the David Geffen School of Medicine at UCLA. Dr. Nelson oversees the women's health care programs at Harbor-UCLA Medical Center and in the coastal county clinics of Los Angeles County. Apart from being a master educator, as evidenced by her teaching awards, she's also a busy researcher. She's been awarded over $50 million in grants from the NIH and other commercial sources, and she's the medical director of the research division of the California Family Health Council. She's also a prolific author, having written 200 articles, 65 chapters, and 12 books, and many more counting. In just a minute, I'm going to invite her up to give us a few words of wisdom. But I also want to welcome you to stay on from 9 to 10 to join our community partners in a roundtable workshop environment to brainstorm about efforts to address unintended pregnancies in our state. So please join me in a round of welcome for Dr. Nelson.
Well, good morning to everybody here and to all of our virtual audience out there. I think getting everybody linked in on this problem is going to be, I think, very exciting. And I don't mean to be negative with my title here, but it is frustrating, isn't it? That in a time when we have availability of the most effective methods of birth control, reversible methods, we still, in fact, we have higher rates of unintended pregnancy than we did before. And it's kind of interesting to sit back and from about 10,000 feet try to think about why this might be going on, and very importantly, what can we do to make a difference. And so part of what I'm doing here today is going to be a little bit of outlining the problem, but more importantly, maybe getting us to think outside of some of the usual boxes that we think in. So let's go for it. I do need to confess that I am involved, as you heard, with many pharmaceutical companies in developing new methods of birth control and trying to keep them on track to keep working on dealing, particularly in the controversial area of contraception. The time I want to spend with you today is to look at those barriers. Why is it when we have effective methods and when we have methods like birth control pills that should, if you took your pill every day at the same time, have failure rates far less than 1%. But in regular use, anybody know in typical use what the failure rate is for the pill? Very close. It's 9%. He's absolutely right. Okay, and that translates into 1 million women every year in this country getting pregnant when they are, quote, on the pill. Now, they certainly have not been taking folic acid and coming in for preconception care because they were contracepting and didn't think they were at risk, were they? So we want to talk about ways we can counsel women about the methods we have today. We don't have to hang around till the magic bullet comes out, because I don't think there is going to be one method that's going to work perfectly for every patient, to see how she can become even more effective at using the methods we do have. And then stepping back a little bit and looking at the image of contraception in this country and how that image itself plays so very strongly into this terrible failure that we're having for success of contraception. Well, to start, here's a cocktail party piece of information. 1 million conceptions occur every day, worldwide. 50% of them are unintended. 150,000 are terminated, and every day 1,000 women die from pregnancy and pregnancy-related causes. And if you put those numbers together, you realize that half of those women who died did not want to be pregnant. And that's a terrible, terrible loss. So we can do so much better with contraception for all of those outcomes. It's not only on the mom, but on the little ones. Now, what did this mother have before she got pregnant? Say aloud. That's diabetes, okay? Now, I would personally not like to be the vaginal canal through which that baby came, sort of a burly little thing, but this baby's real problem is sacral agenesis. Um, Never be able to walk or control bowel or bladder function. And we know that our diabetics have the regulative risk is about 242-fold increased risk. And if we talk about what you and I want for daily control of our diabetics in terms of their glucose levels, you're happy with fastings less than 120, yes? Walking around? And what are you happy with for a 2-hour postprandial? Something under 200? Okay. In pregnancy, we want that fasting in the 90s, and we want that postprandial less than 120. And if she doesn't have that kind of tight control before she gets pregnant, we have preventable tragedies like this occurring. So this whole idea, you can either treat every reproductive age woman as a ticking fertility time bomb, right? Or you can help her plan and prepare for pregnancies. And the sicker the woman, the more protection she needs, right, from unintended pregnancy. We need to optimize her health even more. So we look to see the contribution that contraception has made to health in general. And we've seen worldwide a significant increase in contraceptive use among developing countries in the last 20 years. And what we've seen is maternal mortality deaths, absolute numbers of deaths, decrease. I told you it's 1,000 women a day. That's how many jumbo jets crashing filled with reproductive age young women. But it used to be 600,000 women dying. And as the numbers of women grew around the world, the numbers of pregnancies potentially and the deaths could grow, we actually saw a decline in the numbers of deaths because more women are contracepting. And we've seen that maternal mortality ratio decrease, and it could decrease by another 40% if the unmet contraceptive needs were met. And you say, but wait a minute, how did that get into the ratio? Well, because you have a moment to prepare them for pregnancy. So the women who might have had preventable causes for their death are treated ahead of time. I'm focusing a little bit more, and I know you guys made headlines. Yes? Highest rate of what? Yes, unintended pregnancies. And adolescent pregnancy rates, if you look around the world, there, in the last analysis that just came out this year, complete data were available in 21 countries around the world. The U.S. was one of them, and it was for 15 to 19-year-olds. And the highest rate among those 21 countries was the United States. For every 1,000 women who get pregnant, we have 57 pregnancies and 34 births. So these are the young women. The lowest, to show us what we could do, would be Switzerland. Is that amazing? Where they wind up having 2 births per 1,000 adolescent women. Abortion rates range all over the place, but what we want to do is really prevent the pregnancy and the trauma from the women. In countries, and those would be less developed countries where there were not complete data sets where they could estimate, you can see the rates are highest in areas like Mexico, where they're twice what we are. And the number of teen pregnancies greater than 500,000 a year occurred in 3 countries around the world, and one of them was ours. Ethiopia, we're up there with Ethiopia. I'm not quite sure that that's our success. We could do so much better. How many of you are familiar with a choice study? Is that something? Yes, some of you know this. And this is something that has come, it's a really artificial study in a way that it was provided, funding was provided by an anonymous donor, and word went out in St. Louis for they didn't have access, poor women did not have access to effective contraception, and they said, if you come on in, we'll give you free contraception for a year. And they gave them a limited menu of things that they could choose from, and there was freedom. If she started with one method and didn't like it, she could move to another. But by and large, it was the 2 top tiers of efficacy, the top tier of all being implants and IUDs, right? And the second tier being injections, pills, patches, and rings. And they have given us astonishing data about what women can do when they're counseled, motivated, and I'll show you some of this. But what they found in their study that was providing the no-cost contraception, and very importantly, with focused counseling. In my state, we are able to give free contraception all the way up to 200% of the federal poverty level. So any method that they want to use, they get for free. But we don't have the uptake in the most effective methods that these people did. But what they were able to demonstrate was a significant reduction in abortion rates, in repeat abortion rates, and in teenage birth rates. So every which way you slice the program and the outcomes that you wanted to do it, you could see a difference. Now, many people are going back and they're saying, well, under the new rules, everything's going to be free, so we shouldn't have to worry about that anymore. Well, I think that the ACA is actually going to create, even if Hobby Lobby is overturned and all of that, that creates tremendous pressures on people in primary care who are up to here with patients anyway to now have to learn a whole new skill set and do a lot more counseling to keep the momentum moving. We're going to have other issues about confidentiality and whether in very busy practices people are going to have the time to offer the long-acting, very, very effective methods. We are bolstered, very encouraged by the fact that the American Academy of Pediatrics came out last fall and said, given the efficacy, safety, and ease of use, LARC methods, and those of you who don't have decoder rings, that is long-acting reversible methods, contraceptives, and that is implants and IUDs, that those should be considered first-line contraceptive choices for adolescents. So that is their statement. We should be starting with the most effective, and then only in women who decline those or are not candidates for those do we move to the less effective methods. And we should not be starting with something that we know has a low success rate and making those women fail that method before we offer them the most effective. ACOG is behind implants and IUDs and has been for many years. And I want to just point out the second thing, which is today what we're looking at is one of the biggest barriers to getting access to these effective methods is the lack of spontaneity or responsiveness. She comes in today because she needs contraception. And what do we tell her? Well, I've got to check with your insurance. I want to wait for the lab test to come back. Why don't you come back on your next period? Well, if she's lucky, she'll have her next period in less than 9 months, right? Yeah, we don't want her to get pregnant in the meantime. So building the bridges, and some of these bridges are the things you're going to talk about today. What can you do to reduce? But the streamlining that has come out really makes a huge difference. And if you're not aware of the U.S. medical eligibility criteria, which really evidence-based, not labeling-based, but what is safe for women with a variety of medical problems to use for contraception, and then how it is that we're revolutionizing the way we give contraception to be very responsive. And then if you honestly can't do it that way, giving her an effective bridge, giving a brown paper bag of condoms, or telling her to go to the store and buy the condoms is really not an effective method. It's fraught with problems. So here we go. This is testing. Are you all awake? What percentage of sexually active couples will experience a pregnancy if they use no contraception for 1 year? How many of you vote for 20%? Nobody thinks it's 20%. 40%? Okay, I see some hands. 55%? Okay, 85%? That's why there are 7 billion of us. Okay, and you're absolutely right. None of you, I've actually had medical students at UCLA. I think it's about 20%. Well, that's what it is the first month. Okay, and then you got all the 11 other months that come. So yes, to really appreciate the fertility challenge that's there, right? And after 2 years, it's 90% will. So there is a risk, and it's every day we look at the possibility and evaluate month to month. Of course, our adolescents, based on their wisdom and extensive experience, I think you've had this too, right? They'll come in, well, I've been having sex for a month and a half and I haven't gotten pregnant. I don't think my body needs contraception, you know, and math is not a strong suit of these people, and neither is looking into the future. For them, the future is next month or maybe a month and a half or maybe till the next school year if they're really long-range planners. So really capturing them and understanding what's going on in their lives and how to motivate them. Okay, here comes my next question. What percentage of U.S. pregnancies are planned and prepared for? If we want that woman with diabetes to have a hemoglobin A1C that's below her hemoglobin, that would be good. Or that she's had her pap smear done, or she's been on folic acid, any of those things that we know make better babies. We want them to be prepared for. Just being planned, oh, we're trying to get pregnant, is a wonderful warm fuzzy, but it doesn't really get us the action plan that we need. So today, show of hands, 20%? 37%? 51%? Unknown, we don't keep statistics. We would be shamed by those statistics. Those of you who resonated with the 51%, that is the unintended pregnancy rate in this country. Okay, so I'll come to that in just a second if I can. So here we go. Right today, we've moved up from 49% to 51% of our pregnancies are now unintended, and that has been increasing since before we got IUDs and implants. Maternal mortality rates in this country are the highest that they have been in the last 2 decades, and part of that is that more high-risk women are conceiving. In addition to that death and dying piece of obstetrics, we would have that bolstered by even larger numbers. Another 60,000 women every year almost die or would die if they weren't delivering in hospitals like this, where they can whisked off to the ICU with their, their seizures or their sepsis. There are absolutely no statistics on planned or prepared for pregnancies, and sadly, as important as we've been talking about, and I'm hoping you'll talk among each other, how can we make this happen? There is no coverage for preconception care. The Institute of Medicine turned that one down. They said, oh, that's part of well woman care. And it's like, excuse me, right? The challenges are different. When she's trying to get pregnant, it's different. And I'm pleased to see that in this hospital, they are offering long-acting, the IUDs and the implants, before the woman goes home. But there isn't any cover for it in most of the states. There's no reimbursement, and I understand you guys are trying to work this all out. I'm in California. We don't have it covered. And it was embarrassing because the very first state that approved it was not New Mexico, Colorado, or New York, one of these forward-looking ones. It was South Carolina. And California is now 13 states behind South Carolina in approving this. This is really, really embarrassing. So we have a lot of challenges. There's a huge vocal group that really doesn't know the facts of life, and we just get exhausted trying to answer that misinformation. But if you let you let a lapse go by, somebody thinks it's a correct information, and we continue to perpetuate the myths. Sex education has been stripped from the curricula of many schools, and getting it back out there. How can they learn about their risks? How can they learn about how to protect themselves? We've terrified women with those little package inserts that list all the terrible things that happened to women while they were in the study, not necessarily as a result of the use of the method. I'm always amazed that birth control pills cause pharyngitis, aren't you? But women got colds while they were on their study, so we have to report it. And this idea that pregnancy is a natural condition and so very wonderful and safe. It's a medical condition. It's not a magical experience. It's still subject to the laws of health, and bad things can happen. So you really want to make sure women are healthy before they're pregnant, and that they want to become pregnant, that they're not taking these risks with no benefits. I'll bet you have some of the challenges we did. This was last year. I'm carrying into this year. How many of you have hospitals where women can't get tubal sterilization? Any in your communities? Yep, they are there. Pharmacies that will not give out emergency contraception. Yep, you probably have some that don't even give out birth control. Pharmacies that are now locking up the male condoms, so you have to go find a clerk to open them to let them in. They tell you that it's because people are stealing them, and I hate to hit the bottom line of a CVS, but okay. But the pharmacists say they just want one more chance to talk to that young man before he makes a mistake, like having sex without a condom. Let's talk about that. And certainly we have providers who won't give IUDs because they don't know the mechanism of action. And there are legislatures. There was one in the state of Colorado. I don't know that you have them here, but with the definition of life starting with conception, they thought that would completely make illegal birth control pills and IUDs. And that shows that they just didn't know how those things work. And it's so very sad. And so we're left with cartoons like this. I'm sorry, lady, I'm morally opposed to the birth control pills. But what is he selling instead? Yeah, okay. So, this is actually a good one. What percentage of women who are given a new prescription to start birth control pills fill their prescriptions on time for the next 12 months? I'm looking around the audience here, and I see a fair number of Y chromosomes. So you may not have had personal experience with this, but some of you double X folks, if you could share with people, confirm this. If a woman gets a prescription for a year's supply of birth control pills, How does she get it distributed to her? 1 month at a time. And if she's going out of town and she comes in early for a refill, what is she told? Too early. You can pay for it out of pocket, but the insurance company wants. So you have this window, of 36 hours before you need it that you can come back in and get your next refill. And we go to women, why is it women miss months? Why is it they do this? And we beat them up for it. But this was a study. We got a hold of the Vericept data. We had 1.7 million new starters we followed over time. And just for 1 year, the coming back within 2 weeks of the time that you were supposed to come back was counted on time. We had less than 30% of women for 1 year filling every prescription on time. Is that amazing? On average, women fill 8 out of every 10 months. And there may be good reasons because he's out of town, they're not at risk. But what people don't understand is that the risk of thrombosis, the biggest thing we're worried about with estrogen-containing pills, the risk goes back to baseline. Remember, at the highest time for clotting is at the time you first get exposed to a birth control pill. And all you have to be is off for 1 month, and you go back to that baseline. So the start, stop, start, restart pattern actually increases the risk of VTE. It's better to stay on them rather than it is to interrupt the use of them. So these numbers just blow you away, and you understand that why we have that 9% failure rate. Well, the question is, why is it do we have these problems? And I'm going to toss some ideas that have come from not only me, but certainly from observations and studies that have been done over the last several years, people who are befuddled by this. If you talk to patients, you'll find out that pregnancy is not something that they think women should prepare for. We just did a study looking at 250 women, and I'll show you the results of that. Very high rates of ambivalence. Part of you wants to get pregnant, the other part knows, well, maybe shouldn't, right? And when that throes of that ambivalence, maybe there's not quite such emphasis given to using your method correctly and completely. Tremendous underappreciation of the health risks associated with pregnancy. I'll show you some data on that. And because of, baddrugs.com, tremendous overestimation of the risks associated with the use of contraception. So this was one focus group. We've done others. The concept of a planned pregnancy, they don't even know what you're talking about. I've had patients, when you ask them, when do you plan to have your next baby? Have you been told that you have to ask one question? And there are variations on it, but, and you're making reproductive life plans with the patient, and you ask her, when do you plan to have your next pregnancy? I've had a patient say, Dr. Nelson, pregnancy isn't something you plan for. It's something that happens to you. And that's so deeply ingrained because pregnancy is a blessing. Are you with me on this? That this isn't something that they have any control over their fertility at all. And how we drill down to that, build on their self-esteem, and talk about better outcomes rather than you shouldn't get pregnant now, which is the message that teens hear us saying when we're inviting them to have contraception, but talking about how it can make the outcome even better. Planning for pregnancy can be very stressful because if she fails, then we're going to label her infertile. And that is a huge burden. And when people do take control of their fertility, I think we have to respect that possibility is there. This was another study, people who did get pregnant and admitted that at the time they conceived, they absolutely did not want to become pregnant, but they hadn't used any method at all. And it's like talking to teens. Why did you do this? Well, over 40% didn't think they were at risk at that point in time. And then you can get into why didn't you think you would? But I love this study because it quantified the extent of ambivalence. I think that this is out there. And there's not only ambivalence, but there's conflict. It's not neutral, okay, maybe part yes, but very strong conflict internally. So some really good work has been done. This was a survey that we did, English-speaking women on our research campus. So these were not just my low literacy, indigent patient populations. We put some of those in them, but only less than 14% identified. I gave them a list of health risks that are clearly associated with pregnancy, like blood clots, right, and diabetes and high blood pressure, and those only 14% correctly identified that all of those risks went up in pregnancy. And my favorite question that I snuck in at the end is, which do you think is more hazardous to a woman's health, birth control pills or pregnancy? And this just, I knew it was coming, but every time this happens, it just shocks me that more than 3/4 of the women rated the pill as being more hazardous. And so if women believe it's unsafe and they don't recognize the risks of pregnancy, of course, they don't see a motivation to get ready for pregnancy. And we're going to keep on going with this. Now, I have to tell you that the more education a woman had, the more likely she rated the pill as being riskier. 81% of our people who'd had at least graduate work rated it that way. My maybe GED people, it was only 61%, but it still was the majority. So how did we get there? It's just astonishing. There has been a plan. We are supposed to help women develop reproductive life plans. In part, the thought is that if we ask them about this, that then they'll understand that that's a norm. The downside of asking them to come up with plans is they're going to have to fabricate information for us, and they'll get frustrated with us because we're asking them to do something they don't feel in a position to do. So I'm just talking about this. My favorite is that first question that we're supposed to ask. Do you plan to have any or any more children in your future? And they characterize that as an open-ended question. Maybe I've read the definition of open-ended, but it does allow for branching because you have one response if she says yes and another one that she says no. So clearly these are the ways that to try to open up the discussion so she can put it into context. And I'll leave it to you to talk about, but I'm thinking that that actually may not be the best question to ask. We asked another 250 women about their pregnancy plans, and it was amazing. The only people who really could give us confident answers were the women who were planning to get pregnant this year or had already finished their families or maybe finished plus one or two more kids. Those women never or were trying to do it. And everybody else kind of hemmed and hawed. And I think that's reality. So again, trying to get us to come up with something that can really answer. And not surprisingly, even in a clinic where everything is free, there was very little association between what the woman said she wanted. For instance, if she wanted to wait at least 3 years, we found that only 18% of the women were using IUDs, implants, or abstinence, methods that were really good. And we had 7% were using no method whatsoever. Now that's a good way to delay childbearing, yes? And I already put abstinence into the best method, so that obviously these were sexually active people. And we had 29% of them were using, withdrawal or some of the barrier methods that have very high failure rates. This is an astonishing article, and if you have a chance to look at it, it's just out in very, very recently. And it was a focus group, and I love the title because this is the answer she got from those women when she asked about pregnancy planning. And it was, can you just see the eloquent shrug that came with it? It just happens, right? Can you see that resonating? You've seen that in your clinic. They had low-income women, and they were asking particularly groups that had not been adequately covered by previous surveys. Again, they focused on education and knowledge, and that's where we've been, but they said, wait a minute, maybe we're missing the target. And what did they find? Well, they said that most of the approaches we do to evaluate pregnancy is assuming that women are using logic to decide whether to have unprotected intercourse. And the real world, actually, they say it's much more complicated, it's contradictory, ambivalence often rules the day. So I think with that, the themes that they found, the conclusions, and these were very important, I think, to some of the discussion you're going to have, that women oftentimes do not see that they have reproductive control, or they really don't understand the risk of fertility. Okay, that's 85%. They don't understand the risks of becoming pregnant, all of those. They don't formulate pregnancy intentions. After it happens, they scurry on in for prenatal care, or they don't, depending on things. But there is so much fatalism if it happens, right? It's going to happen to me more than even the ambivalence, which we have noticed in the past. The benefits of planning for pregnancy are not known to them. This is from a medical standpoint. What people plan for is maybe the finances or the social aspects of becoming pregnant. The baby daddy will stick around, something like that, or we have an apartment, or maybe I got my GED done. The determinations about intendedness of pregnancy, and I'm going to have to take an aside here because I haven't really defined that with you. When I say that a pregnancy is intended, does that mean that it's planned for and prepared for? It doesn't mean that. Does it mean it's planned for? Because we'll see oftentimes people will interchange unintended pregnancy rates with unplanned pregnancy rates. Have you heard that? 51% of pregnancies in this country are unplanned? No, actually, that's not true. Okay? Truly, an intended pregnancy in 2015, that's right now, yes? Okay, the definition of an intended pregnancy is not one that's planned, not one that's prepared for, it's one that is not unintended. That is the definition. So you have to ask yourself, what is an unintended pregnancy? And by definition, it is one that the woman declares she did not want to conceive at the time she did. So I'll give you a real world. This morning in LA, somebody walks into my family planning clinic at Harbor, late on her period, do a pregnancy test, turns out she's pregnant, you tell her she's pregnant, and she gives you this, wow. Now, you're classifying that pregnancy. Is that intended or unintended? Every rational person in this room is going to say that's unintended, yes? But by the classification system we use, it was intended. She didn't say, oh, I didn't want to get pregnant. Seriously, that's all the ambivalent pregnancies are considered intended. And even when you take that mushy, squishy, totally amorphous group together, we're only at 49%. Is that horrible? Truly. So, the problem that we have is that the intendedness of the pregnancy only occurs after the pregnancy is there, and she's filtered that reality. It isn't prospective. Do I want to become? It's not that logical. Well, let me see. I'm about to have unintended pregnancy. I'm cycle day number 3. The probability of conception here is, besides that, he'd make a pretty good father. No, it's truly after the fact in that kind of a setting. And the last thing I want to point out, because I think this is new understanding, the concept of planning for pregnancy in many places is only appropriate in places where you have the money, you have the place to, the dream that you would have for taking care of the child, or oftentimes outside of marriage, it's not right to plan for pregnancy. It's okay to be pregnant and to have the baby as a single mom, but to plan to have it is not acceptable. So if we think of all the teens who are getting pregnant, right, many of them are not in the condition where they would think or have been told that it's appropriate to plan for. So we're having to change a lot of their paradigms to ask them to take on a responsibility that may be very difficult for them. I think you run into this all of the time, this health literacy problem that we have. It is estimated that we need to have 9th grade education to be able to navigate the U.S. healthcare system, and so many of our patients are maybe around 3rd or 6th grade, and it's so very sad to see. And we have to screen because people can conceal their illiteracy very well. They actually cope well in life, but they just can't respond to how to take the medicine or what the side effects are. So coming back full circle, what we're talking about is contraception. And contraception is like very much like many of the stuff you do in terms of it's a preventive medicine. Just like high blood pressure, people don't take their blood pressure medicines to keep from getting headaches, it's to keep from getting strokes or heart attacks. And whereas those preventive measures are oftentimes supported by the family, right? There's an agreement, we don't want dad to die of a stroke or a heart attack, so take your meds, dad, right? So his non-taking of that is not a secret wish to have a heart attack or a stroke. We add on to it all the ambivalence and the external pressures that come with being a consistent user of contraception. Maybe the mother-in-law hides the birth control pills. I've had husbands pull out the IUDs, right? This sort of thing happens all the time where the woman doesn't even if she does take control, it gets taken away from her. And technically, pregnancy is not a disease, but it is a health risk, and we need to make sure people understand that before they embark on it and get as good healthy as they can. You can see the numbers there. And when we're talking about the contraceptive risks, it never is measured against what would happen if they had sex without contraception, got pregnant. So every method of birth control that you would offer a woman has to be and always is safer than pregnancy, but patients don't understand that. So just a little aside, I think contraceptive family planning folks used to be the good guys. And so the question is, you know, how did we slither? Why are we such public enemies right now? And I don't know if you know this, but at the time that the UN was formed, we had the 4 freedoms, and there was actually a push from many of the women's groups and some male support too, to make a fifth freedom for women around the world, the freedom from tyranny of excessive fertility. This is actually from a poster. And of course, it was ignored. We only had 4 freedoms, and we're fighting to keep those going too. But it lets us know that there has been a cry, even before we had birth control pills or any technology to do this, but to give women, some families, some control over their fertility. We've been through some amazing booms and busts. Do you all remember Norplant? Do we have, I mean, an incredibly safe method of birth control, tremendously effective. Every time something gets successful financially in this country, we get targeted class action suits. Just think what's on the nightly recruitment on television right now. Lawsuits keep the old issues in the press. People keep thinking there must be more problems. No, it's just that case moving along the court system that's there. And unfortunately, there's been politicalization and polarization around issues of family planning. And you'd think that we would find common ground in prevention of pregnancy and promotion of health of mothers and babies, but we haven't found our way there just yet. So again, women, if they don't know the risks of pregnancies, cannot make an informed choice. They may know the risks, but they don't know the benefits. And so their commitment to using the method may often be affected by this. And I want to talk just for a second, if I can, about the power of images. As clinicians, applied scientists, you know, we spend our time gathering the facts so we can be well informed, so we can share information with our patients, so we can teach them, right? We feel really, really guilty if we try to manipulate or influence. You know, we've all been taught, if the patient says, "What do you think I should do, doctor?" You know, unless it's take your insulin the way I'm telling you to take it, that sort of a thing, we often, well, you know, it's really on you. You think about it. We don't, you know, this is your life, that type of stuff. And we feel a little, well, honestly dirty in manipulating. And I just want to, you know, we counsel and we educate, but I'm wondering if we're effective. And I think if we're leaving the images of family planning the way they are, I think we're not. So I think we need, maybe not on a one-to-one, but look at the big image of birth control. And I want to share some images that we have with you. I mean, how does this guy, can you just see him beaming? See his hand on the car there? Yes? Okay, well, it gets better. This guy's just kind of cash. This is a cat. I own this, right? But this is my very favorite. Any question, this guy is not into this car? Absolutely. So you look to see, and this guy, look at that body language. See that? And I looked at, you know, how does he feel? Well, he feels powerful. That is a noisy engine, right? And it draws attention to him. This car is outrageously expensive, and it eats up gas like anybody, so he can afford it, right? This is his testimony that way. He's in control. I mean, he has this enormous engine throbbing beneath him and just waiting for him to shift the gear, right? And he's happy and fulfilled as a man. That's a sleek car. Only he can fit into it. And if somebody asks him to pick up the laundry on the way home, tough noogies, there's no trunk here. There's no space for it. You know, this is my world, right? Now, on the other hand, how would he feel if family planners had named this? Well, gosh, we're rational, factual folks, and we would never have called that a sports car. And obviously, he's not an athlete. We would have named it for what it really is, a rapidly accelerating loud car. Yes? And economically, we would have called it RALC. Okay, what does that sound like? And maybe be surprised it didn't sell. Why do I say that? Because we did have an opportunity as physicians, as people, to inspire women with these new contraceptives, right? They are extraordinarily effective, incomparably safe, extremely convenient, highly cost effective, and what did we call them? LARC. How many of you have heard that expression? Long-acting reversible contraception. Totally meaningless to the patient, yes? Absolutely. What does it mean? Nothing. Maybe if you spelled it differently, it could be a songbird, right? But we just don't respond or think of opportunities to inspire people with the things that we have. So if you know what it means, I mean, being reversible actually turns off women who finish their families because they don't want to think about reversibility. We want to protect their future fertility because we know about regret in the future. But at the moment they make that decision, they want to close that door on their part of life. So kind of an interesting thing. So we want women to feel confident when they pick a method, right? She's chosen a top-tier method that she's in control. She can decide when she wants her next pregnancy, that she made an excellent modern choice. that her method is convenient, and she should be relieved, right, with her decision, the outcome that's there. But what do women feel? They're worried. Seriously, and that's in caps. It should be, bolded with exclamation points. She's worried about things that'll happen to her while she uses it, because we give her these big, long lists of things that are absolutely not attributable risks, but there's stuff that happened with her. We should recognize the stuff that are real risks to her, but the other types of things that we have good knowledge that isn't attributable. And she's really, really worried about what might happen when she stops it. There's a procedure going in, a procedure coming out. And I nabbed these images from websites of women who were complaining about their methods. Look at that misery. That's what young women are looking at. And can you see that pouty little face at the bottom? That's the implant user. Oh my gosh, is that going to catch on and inspire people? No, totally not. So we need to kind of look at how we do it. We need to choose our words. Birth control. We had more than 35 years ago, we were told, don't do that. And who told us don't call it birth control? It was Malcolm X. He said, my people think you're trying to control our numbers. Call it family planning. Can you imagine the word family planning came from Malcolm X? Family planning has a rich history, truly. You know who approved Title X? Richard Nixon. Okay, so interesting pieces of history. We have this. We have contraceptive implants. That's technically correct, but is that a good word to be sharing with patients? What in the world is a contraceptive vaginal ring? Do women know where their vaginas are? I remember the first the ads that came out for that product looked like a hula hoop with a force field around the pelvis. How can you discuss these things? So, what can we do? What do those terms do our customers? And we have to realize our patients certainly are customers, but their family and friends are influencing them. The public is. The media certainly will pick up on any bad story, try to get a good story, news story out there. You know how hard that is to do it. School boards who are making decisions about what children are allowed to learn about sex education. Legislators and judges play very important roles too, and oftentimes very poorly informed on these issues. So, little Martian comes down and he'd ask us rather embarrassing questions. Why are the most effective methods used the least by Earth women? Why are women so worried about the safety of contraception? Why do couples take sexual risks? And why is sex used to sell so many products in the United States, but never used to sell contraception? Have you thought about that? Right? Like, for instance, I love this one, seriously. Like, this is an old one, but Clinton reminded me. Never mind. Okay? Cars. Could we sell a car without a sexy woman? Yes, we could. The power, that would come in, but sex helps sell it too. That's baseballs. Give me a break. Okay? French fries. Real fries in a fake world. Okay? Tennis shoes. We're selling tennis shoes with kiddie porn. Okay? And yet, I have this force field that looks like a chastity belt for a vaginal ring. Come on, this is ridiculous. So, question we've got to ask ourselves is, do we really know our patients? Do we know why they choose the methods that they choose? How can we influence that? Why do some women not use any method when they say they don't want to become pregnant? I know we're not dealing with rational people, and I know that this is just a particular application of the frustrations why people don't take any of the medications that we're giving them. But this involves bringing another life into the world. And I think that responsibility and really understanding a little bit better, and we have tools to do things. Why can't we motivate the folks to use methods that work well? And looking particularly at the contraceptive needs of teens, we want to preserve their fertility for future childbearing. A very important health goal here is their body image. Teens are very much worried about how they look. If something gives them a pimple on the tip of the nose, forget it. They're looking to look beautiful. We also know that they have STD and cancer risks that we have to try to minimize for the future. And efficacy, privacy, and convenience are all mandatory features of what we want to provide them. So I think as we're trying to find the methods that come in the best to help the folks. So where do we start? I say we put family back into family planning, okay? We're not contra anything, right? We want to be in support of. And so we are the good guys. Let's get the good guy back. Let's use images of happy people, right, with healthy children. or deciding to pursue a career, giving them the choices that they want to pursue, giving them that control back again. We want to close the gap again, and we get so tired of talking about the facts of life, but every day a new person becomes an adolescent, right? And somebody new gets elected into the legislature. So we have this unending stream of people that we need to keep well educated and well informed, just even with the basic facts of life. We want people to know that there are differences among the methods and how well they work. The very top tier are the implants and the IUDs. And we want to do what we can to streamline. And this is in addition to that US MEC that I talked about, medical eligibility criteria that lays out who can and can't use methods for safety basis. This tells us, you know what, when you're seeing a woman for contraception, separate that concern away from well woman care. So if she hasn't had a pap smear, she hasn't had her chlamydia, that's well woman. She doesn't want to get the test done for today for some reason, but she wants the pill. Can we still give her the pill? Absolutely. The only thing we have to do to give a pill is to get a good history and measure her blood pressure. She doesn't need any of those other things done to her today. So I think that that's important. Know what is the minimum we need to do in addition to the good history, so we know that she qualifies for it. But is that amazing? And the other thing is we want to start every method the day she's there, right? And if you're not giving it the day she's there, remember the progestin-only pill is the go-to option. If you have a question, you have to get some follow-up, get her medical records, whatever it is. There is only one contraindication to the progestin-only pill, and that's recent breast cancer. And very few people have it. Now, can you send them home with a bag of condoms also? Totally, for STD protection. But giving her something that she can start today that will work as well as a combined pill in typical use does, right? And you don't have to have her screened by a lot of other things going on. And I just thought, not that I want to slam condoms because I do a lot of my work in condoms, but this is real world. Comments, reasons why you didn't use a condom. Number one, I didn't know him well enough to ask him to use one. Number 5 is real. People don't like latex condoms. The dirty little secret is that 30% of erections are lost during the placement of the condom. Of course guys don't like it, right? It's cold, it's rigid, it's cold for her, right? So we've tried very much to make them much more pleasurable. We reward their use. If you don't know about condom accessories we have out there with the little ribbings and the flavors, have you seen the little vibrating rings that we put at the base of the condoms? Seriously, I don't think they're outlawed in your state. Go take a look. They are so much fun. And you can really, they started off with a little hum, okay? So it was just a gentle little vibe. And then they went crazy. They have 4 different things. Some are 1, 2, 3, 4, okay? And it got to be an equality issue, and they now have vibrators on either side of the ring. I don't know why. I mean, if he's going like this, so is she. But now they have the one for her and one for him. So again, 20 minutes worth of battery. So that's what, 10 different uses, whatever. But I think we need to recognize that people want to use things. They don't need to be told to use them. They know it, but they just don't like to. So find ways to make them more fun. And actually, we'll come to that. Here's the next 6 reasons. I love the partial credit. Well, I did once. Yes, she looked clean. He's too big for the condom to fit. Okay? We only have 3 sizes of condoms, and that may be right. But we need to know our condoms. If it's squeezing the glands too much, they actually have a condom called Her Pleasure, which just drives me crazy because I do a fair amount of work with sexual dysfunction and lack of libido. If a little piece of, saran wrap at the top of the vault, flapping around, drove her crazy, then we'd have it all solved. But know the different condom size. You can't get AIDS from a woman. I already have herpes and warts. Well, why not add a pregnancy? Okay. All right. So what do we want to say? My suggestion, and you can talk about this, is I think we need to run from the word natural. We will always in medicine lose the argument about natural, right? Pneumonia is natural, AIDS is natural, cancer is natural. We're promoting health. And I think that when we're talking about planning for pregnancy, health is where we are strong, and we want to make people to really embrace it. Uncontrolled fertility is a problem. It's not only a public health problem, a financial problem. For teens, it affects their whole potential for a lifetime. and the costs are really large. But to realize that. And we really want to think of things instead of segregating ourselves into silos. Let's all come together. Let's let infertility and fertility control be part and parcel of a continuum of services that we want to help people with. We want to make the most of every opportunity that we interact. Really sad data here about providers giving out teratogenic drugs and not advising women to use effective contraception. Well, if it happens, it happens. You know she's not going to be a good pill taker, right? And that she's going to have unprotected sex. She's going to have a million excuses. So it will happen, whatever the fates are. That's the woman who say, well, if you're not sure you're ready for pregnancy, why don't we? And then you get over to something like that doesn't require any work to make it work. And when you're ready for pregnancy, you can come on in, we can take it out, and you can get pregnant. So just as a different way of approaching things, think about how you might want to do it. So we want to find out what she will use. We want to make it attractive. We want to start it now. And because people are people, unless she's using an IUD or an implant, make sure she goes home with a full supply of emergency contraception. The more cycles of birth control pills that we can give, if we can give a whole year's supply of birth control pills, and that's going to take some pressure for the insurance companies, but it reduces teen pregnancy and abortion rates. We have that data. Just amazing. Give her a backup method because she's going to stop one along the way. Make sure she doesn't have unprotected sex, and do encourage her to plan and prepare for future pregnancy. So now and lots and more. Thank you very much. We have some questions? Turn on the lights. Any of our offsite? Oh, we have a question. Yes, please.
That was a wonderful speech. Thank you.
Oh, thank you.
Can you tell us in a nutshell what the key findings were of the choice study?
Certainly. I thought I had a slide on that, but you're absolutely right. I guess I didn't. So what happened was 76% of women chose implants or IUDs. The teens took up the implants at the highest rate. It was 40% of teens. Pregnancy rates with the IUDs and the implants in teens, they had 1,400 teens in that study. Nobody got pregnant with the IUD or the implant. Overall, the birth control pill had a pill, patch, ring, and and shots had 21 times higher pregnancy rates than they had overall with the IUD or the implant. So clearly, rather than giving people absolute numbers, and normally we do, but this is one that I think is so impactful that we want to share that there is a good reason to choose one of the higher, more effective
And I
methods.
was given
Follow-up?
permission for 2 follow-up questions. One is, what was the choices methodology for motivating the kids?
Oh, this was,
And number 2, do you want to talk about the Colorado study?
I didn't put in the data on the Colorado study, but certainly Stephanie Teal has done a marvelous job bringing effective contraception to teens in Colorado, found a very high acceptance rate, not quite as high as we had with the choice. The pregnancy rates with the teens while they were using those methods were similarly very low. People get very frustrated because the removal requests in the Colorado experience were so much higher. We saw overall that it was somewhere around 15% of teens asked to have the LARCs removed in the first year, which is quite reasonable. In the St. Louis experience, it was a little bit higher in the Colorado, but you're working with high-risk people, and when you buy 12 months or 15 months, you've got a much older woman that you're dealing with, and her chances of successful contracepting or mothering or whatever she chooses. So I think clearly very good demonstration projects, and they had adequate numbers of teens to inform us that certainly you can technically place an IUD in adolescent women who haven't had children. The expulsion rates are actually lower in nulliparous women than they are in parous women. They are slightly higher in younger women than they are in older nulliparous women. But a lot of the things that had kind of worried us about offering, particularly IUDs to young women, really the safety emerged as a very important theme in all of those settings. Thank you for that opportunity. Yes?
You used 2 terms. One, the use of IUDs in adolescence,
Yes.
and the word privacy.
Yes.
How do we decide that we have to communicate with the parent? At what age does it start? At what age it doesn't have to be?
Okay, that's an excellent point. And I think those of you who are aware of all the programs that we have with teens, we always want to involve an adult so that teen has someone of an adult age to talk to, but it may not have to be a parent. This varies by state law, and I think your state law is very similar to mine in that teens can give permission for all forms of contraception. We do not need adult permission, parental permission for any form of birth control. So I think that whether it involves a procedure or not, I know we have to call mom to ask if we can give the Tylenol before we place the IUD. Don't give the Tylenol, just place the IUD. Trying to find ways that teens can talk to their parents, I think, is really an art and a very important thing, because we don't want them to be all alone. But sometimes it's dangerous for a teen to talk to her parents about controlling her fertility. So in that case, you're busy preventing her from getting pregnant while you're trying to help her rebuild that bridge to her the adults in her life. It is a very important, we don't have to ask, don't have to obtain parental permission to do any form of birth control, just as we can take care of them in pregnancy without any parental involvement, right? She can get prenatal care with us, we can deliver, we can do a C-section without mom and dad saying yes or no, right? So this is part and parcel of that. That may be eroded in some states, but from my understanding of what your laws are, and you're probably more familiar, but in the state of California, I certainly have that as an ability. But it's always good to ask that, right? We can test and treat for STDs, for pregnancy prevention, and pregnancy care can all be given. She doesn't become emancipated, but she becomes legally able to give her own consent, not assent. Interestingly, we can't do research on her, though, right? For contraception in many settings. We have to get parental for that.
You talked a lot about the role of ambivalence, and I wonder if you had any advice in terms of when you have a woman who's really just stuck in that ambivalent mode. I have a patient that comes immediately to mind who's HIV positive, so we see her very regularly. Every time we see her, we try to push one of these highly effective methods, and she's like, oh, no, I might want to get pregnant, and then she gets pregnant, and she panics and doesn't want to be pregnant and terminates, and she's done this multiple times.
And that's so frustrating. I mean, you are dealing with human beings, and whether she were HIV positive or not, you're just lucky enough to see her more often. So just as I do with those women in the middle, I try to change the dialogue around do you plan or want to the until you really know you want or you're ready for. Why don't we provide the protection so that becoming pregnant isn't a default option, but it's something she seeks. And in the meantime, we're giving her the most convenient. Why even have to worry about it? Why don't we just give you, these methods that'll work for you and you don't have to worry about it. And when you thought about it some and you really are ready, let me know. But we have to be there to remove it. That's actually been something that providers have been pretty good about in general. There was a huge concern that we would take away women's control of their fertility. I don't know if you know, but when Norplant came out, there were all these crazy things where there was going to be targeted contraception. In New Orleans, one of the city councilmen put in a motion that all black women with illegitimate children on general welfare should be offered Norplant for free. There was no money to take it out, mind you. But can you target any more a vulnerable population? And it was when particularly the OBGYN stood up and said, there's no way we're going to do this. In St. Louis, there was this push to make sure that IV drug abusers got Norplant. And in my state, in Tulare, the day that the FDA approved Norplant, there was a lady who had done terrible, egregious harm to her children. The judge had tried her case and already announced that he was going to give her probation because she was going to go into therapy, and she was keeping the kids. It was very tenuous. But then she walked into the court and he added Norplant as a condition of probation. Talk about get Norplant or go to jail is what it was. And when we as a profession said, no, we don't want to be part of that. We understand we don't want to have drug abusing women getting pregnant, but taking away their control of their fertility is too high a price to pay for that we buy back a little bit of goodwill. But we have to keep our pledge that even if she comes back 2 months later with this crazy reason for getting it removed and you're sinking down that rabbit hole of ambivalence again, we still have kept her control. That was a long story, I'm sorry.
Could we turn on the audio at Wilmington?
Hi.
Any questions at Wilmington?
Pressure, no pressure. Thanks for listening, guys.
Well, one more round of applause, and those of you who are staying, please stay on.
Oh, can we? Yeah. Do you want up here or do you want down there? Would you up down there? Okay, we'll be there. Half a sec. Well, I can come back up and get it.
Oh, you're staying.